studies for a patient with acute diverticulitis. We do CT scan plus oral or IV contrast. That is the preferred test. CT scan plus oral or IV contrast. Other investigations you can do can be abdominal ultrasound, okay, which can be used to pick up an abscess, erect abdominal X-ray of the abdomen, and then upright chest X-ray. And the reason is because for the erect abdominal X-ray, we want to make sure that the patient does not have any air fluid levels, because one of the complications of diverticulitis is what? Intestinal obstruction, right? So we want to do an erect abdominal X-ray to make sure that there are no air fluid levels and intestinal obstruction is not a complication. The next one is air under the diaphragm. If I see air under the diaphragm, that means that air has leaked out of the intestines and it has settled under the diaphragm. And if the patient stands, we know that air will rise. So it will go and settle under the diaphragm. And that is why I'll see air under the diaphragm in a patient with perforation. Other investigations I can do can be MRI. Now, let's talk about colonoscopy. Never ever, please, in your exam, if you are presented with a patient with symptoms of acute diverticulitis, your initial investigations, you should hold on with colonoscopy. Don't do colonoscopy. The reason why you don't want to do colonoscopy is two. Number one, if you do colonoscopy, because the patient's intestines are in that situation, in that acute situation, they are inflamed. And so if you do colonoscopy, you can perforate that intestine. And you can easily convert a simple diverticulitis to something very complex. Number two, doing colonoscopy in the acute stage of diverticulitis can precipitate it again, assuming the diverticulitis is healing. That is why you want to make sure you don't do colonoscopy in diverticulitis. By the way, why are we doing colonoscopy in a patient with diverticulitis anyway? We do colonoscopy in a patient with diverticulitis to rule out other conditions like polyps, like cancer. So while the patient is in pain, well, if the patient has polyps or if the patient has cancer, it can at least wait for a few days for the pain and everything to settle, right? Don't go and put the patient in the OR and say that, the patient will need colonoscopy right away. Don't do that, because then if you do that, you are putting the patient in harm's way. So don't do that. If we do that, we are putting the patient in harm's way. So colonoscopy should be done in a patient who has diverticulitis, and we are going to learn about that. But in the acute phase, if you see colonoscopy in the acute phase, please run away. Don't choose it. Don't do it. Doctors, please, am I making myself clear? If the patient is presented with acute diverticulitis, abdominal pain, fever, C-reactive protein is high, and all those things, and you see colonoscopy as one of your answer options, please run away. Tell yourself that Dr. Boni says I should run away. Now, if you see that a patient has suspected perforation or peritonitis, by the way, I gave you a diagram initially. What equation did I put there which will help me to know that this patient may have perforation or peritonitis? Who can remind me, please? Who can remind me? Well, I put a particular equation there that if you see this, it should let you know that the patient may have peritonitis or perforation. Who can remind me, please?
It's diverticulitis plus hypotension?
Shock and hypotension. Hypotension
and hypertension.
Hypotension, yes. Hypotension. Hypo. Low blood pressure plus left lower quadrant pain in a patient you are suspecting has diverticulitis. Think about perforation. Think about peritonitis. Now, if you have a patient with peritonitis and perforation, then we have to look at other investigations like, liver function test, amylase and lipase. And remember that, what did we say about amylase and lipase? Will amylase and lipase be elevated or decreased in a patient with peritonitis secondary to diverticulitis? Will it be increased or decreased?
Increased.
It will be increased.
And we also learned today that, look, not every elevated amylase or lipase is indicative of pancreatitis. Doctors, I hope I'm building my points clear now. Beautiful. Okay, so I need a volunteer, please. I need a volunteer. I
can go, Doc.
Please go. Yeah.
65-year-old female presents to the emergency room with a history of left lower quadrant pain, which has been ongoing for the past 3 days with associated loose watery stools. The temperature is 37.9 degrees Celsius. The blood pressure is 107/70 millimeters mercury, and the pulse is 78 beats per minute. The question is to list 3 stool investigations you will request.
Sure. So this is diverticulitis plus diarrhea. Diverticulitis plus diarrhea. What other investigations will you do apart from your CRP, apart from your CBC, apart from your lipase? Because you're looking at all the differentials, right? Apart from amylase, lipase, apart from your beta HCG, apart from the white cell count, you have a patient with diverticulitis, but then the patient has diarrhea. Please, can you type your answer for me? What other investigation will you do? Diverticulitis plus diarrhea. What other investigation will you do? And don't be tunnel vision, please. This is something I want you to pay attention to. Don't be tunnel vision. Beautiful. I'm seeing something here. Dr. Samira, why are you saying sigmoid volvulus? Like, sigmoid volvulus is not an investigation, right? We are looking for investigations. Dr. Obina, please, you said IBD. IBD, I don't know what it's about, you know? We are talking about investigations. So, diverticulitis with diarrhea. Patient presents with diverticulitis and diarrhea. What other investigations will you do? Number one, you want to do stool for Clostridium difficile. You want to rule out Clostridium difficile infection. You also want to rule out Salmonella infection. You want to rule out Shigella. You also want to rule out Campylobacter and Yersinia. And more importantly, you also want to rule out E. coli 0157H7 infection, right? Because that can lead to very bad hemolytic uremic syndrome. And then with the stool itself, you also want to do microscopy for ova and parasites. And you also want to rule out Giardia lamblia infection or infestation. So, stool for Clostridium difficile, stool for Salmonella, Shigella, Campylobacter, Yersinia, E. coli 0157H7, right? Microscopy for ova and parasites, and Giardia lamblia. You want to rule all these ones out.